nice story with the truth. But what I've prepared for you today are 3 relatively short cases, which I've affectionately titled Another Bloody Periop. So the 3 cases are Mr. Stent, Mr. A-Fib, and Mrs. Mechanical Mitral Valve, which I thought presented a nice opportunity to review some of the latest literature that informs how we think about holding medications that make you more likely to bleed in the perioperative period, with a particular focus on if you need to hold them, if so when, and where things stand with respect to the concept of bridging. But before I go too far, I figured I'd start with a quick roadmap to give you a sense as to if any of this might interest you. So in reviewing the case of Mr. Stent, I'll review some of the changes put forth in the recently released 2021 American College of Cardiology Revascularization Guidelines. And by the end of this case, we'll see that as stents have gotten less thrombotic, recommendations for dual antiplatelet therapy duration continue to decrease, but that it's also important to consider whether the stent was placed due to acute coronary syndrome or stable ischemic heart disease when thinking about interrupting dual antiplatelet therapy. And in reviewing the case of Mr. A-Fib, who's on a direct oral anticoagulant, I'll briefly review the PAUSE trial. And by the end of this case, we'll see that the DOACs really tend not to require bridging in the perioperative period. And finally, in reviewing the case of Mrs. Mechanical Mitral Valve, I'll review the recently released PeriOp 2 trial. And by the end of this case, we'll see that bridging still remains questionable, as even the subset of patients in this trial with mechanical valves showed no benefit with a bridging strategy. And while I'll focus on just a few of the key components of each of these algorithms, the nuances are vast and constantly evolving. So for this reason, multidisciplinary decision-making with cardiology, surgery, and anesthesia remains very important. Now, I'm not a big fan of medical acronyms, but there's 2 that I'll rely on to help facilitate this discussion. And the first is DAPT for dual antiplatelet therapy, which refers to the simultaneous use of aspirin with a P2Y12 inhibitor, such as clopidogrel, ticagrelor, or prasugrel. And just as a brief reminder, if you were to nick yourself with a razor, one of your circulating platelets might bind to the basement membrane via von Willebrand factor and subsequently release ADP via activation of the cyclooxygenase enzyme. That ADP would go and stimulate a P2Y12 receptor on a nearby platelet, promoting the shuttling of a special receptor to the platelet surface that allows it to bind fibrinogen. Aspirin inhibits the cyclooxygenase enzyme, and P2Y12 inhibitors inhibit the P2Y12 receptor. The other acronym that I'll be referring to is DOAC for direct oral anticoagulants. And the 3 that I'll be referring to in this discussion are apixaban, rivaroxaban, and dabigatran. And just as a reminder, the common pathway acts to convert fibrinogen to the more stable fibrin. And apixaban and rivaroxaban act to inhibit factor 10A, whereas dabigatran acts to inhibit factor 2A in this common pathway, as opposed to the less selective oral anticoagulant warfarin, which acts on several factors in this coagulation cascade. Now, the one other potentially esoteric term that I'll be referring to is bridging, which I'll define here, which refers to the use of a short-acting parenteral anticoagulant, such as low molecular weight heparin or unfractionated heparin, during a period of time when the oral anticoagulant warfarin is not at a therapeutic level. But with those definitions out of the way, I'll kick things off with the case of Mr. Stent, who is a 65-year-old man with hypertension and coronary artery disease, who recently had a drug-eluting stent placed to his LAD 5 months ago in the setting of stable ischemic heart disease, for which he's currently taking aspirin and clopidogrel. And he was coming into the clinic after having a positive fecal immunochemical test with recommendations for follow-up colonoscopy. So in considering what to do with his bloody medications at this time, the first thing you might consider is, do you need to stop them? And to answer this question, it really comes down to the procedural list. But in general, low bleeding risk procedures, such as peripheral skin, avascular tissue of the eye, such as cataract procedures, or the excision of just 1 or 2 teeth, you can usually continue the dual antiplatelet therapy. Very high bleeding risk procedures are those that can bleed into a vulnerable space where even just a small amount of blood can cause a great amount of damage due to lack of space for the blood to expand, such as the spinal canal or posterior eye. And in those instances, the proceduralist will likely want you to hold both the aspirin and the P2Y12 inhibitor. But for cases between these two extremes, these days, most surgeons are willing to operate with aspirin running in the background, but will likely ask you to hold the P2Y12 inhibitor. Focusing on endoscopic procedures, like the one that Mr. Stent was referred for, if the proceduralist is planning to do a colonoscopy and can assure you that they won't be doing a biopsy or polypectomy, you can likely continue the dual antiplatelet therapy. But once they start cutting tissue, they'll likely ask you to at least hold the P2Y12 inhibitor. And if they're planning to excise a very large polyp that's greater than 2 centimeters in size, they might even ask you to hold both the aspirin and the P2Y12 inhibitor. And to get a better sense as to where these proceduralists are coming from, it can be helpful to consider what might happen if we were to continue aspirin during these procedures. Fortunately, most of the heavy lifting for this thought experiment was carried out by Dr. Faraday, a perioperative enthusiast down at Johns Hopkins. And what the literature shows is that if you continue aspirin during these procedures, they tend not to increase the risk of reoperation or death, but they do increase the risk of minor to moderate blood loss that occasionally requires blood transfusions. And if you repeat this experiment with both antiplatelet agents on board, we see a similar picture that they tend not to increase the risk of reoperation or death, but they do increase the risk of minor to moderate blood loss requiring transfusions. And notably here, none of the neurosurgeons were willing to perform this experiment with both antiplatelet agents on board. But like I said, these days, most surgeons are willing to operate with aspirin running in the background. And if we turn briefly to the 2017 European Society of Cardiology guidelines, we find their recommendations for holding the P2Y12 inhibitors, which is based largely on their pharmacokinetics and pharmacodynamics, with recommendations to hold ticagrelor 3 days before the procedure, clopidogrel 5 days before the procedure, and prasugrel 7 days before the procedure, with resumption of the P2Y12 inhibitors on post-op day 1. And the American Society of Regional Anesthesia largely agrees with these recommendations, but they don't mind if you hold them a few days earlier, especially if they're planning to enter the spinal canal with their anesthetics. But once you've made the decision that you're going to hold one of the antiplatelet agents, the next question you might have is, well, how long do they need to be on the dual antiplatelet therapy? And to answer this question, there's a few different places we can turn. There's the 2016 American College of Cardiology guidelines, the 2017 European Society of Cardiology guidelines, and the recently released, just this past December, 2021 American College of Cardiology revascularization guidelines. And a crucial component of all of their algorithms is consideration of what type of stent was placed. But to get a better sense as to why these guidelines keep changing, it can be helpful to take a step back and consider the evolution of percutaneous coronary intervention over the years. So, like the trajectory of modern medicine, the trajectory of dual antiplatelet therapy duration has followed a parabolic arc, starting at just 1 to 3 months, increasing to 6 to 12 months, and now we find ourselves on the downward slope of this curve, heading back towards 3 months and possibly just 1 month in certain individuals. A more accurate trajectory is reflected by some of the literature published over this timeline, once again starting at just 1 month, increasing to at least a year. And there are too many studies to include on this small graphic here, but there have been numerous trials in the last few years looking at just 3 months or 1 month of dual antiplatelet therapy for patients with drug-eluting stents. But to explain this a little bit more clearly, I'll wind the timeline back to September 16th, 1977, when Dr. Andreas Grunzik successfully performed the first balloon angioplasty on Dolph Bachmann. Seen here smiling 40 years after the initial procedure, after learning that the LAD lesion that Dr. Grunzik ballooned open in 1977 was still patent 40 years later. And although Dolph did remarkably well, not everyone was so lucky, with acute closure being seen in 5 to 10% of cases. Fortunately, just 10 years later, Dr. Ehrlich Sidwart and his buddy Jacques Puel introduced the world to the bare metal stent. And although the bare metal stent was good at preventing this problem of acute closure, it introduced a new problem, which was that there was a foreign body in the vessel bed, which provided a nidus for thrombus formation. So Dr. Antonio Colombo proposed adding a second antiplatelet agent to the regimen, at the time taclopidine, with initial trials looking at it for just 4 weeks. And although the dual antiplatelet therapy was good at preventing thrombus formation, it wasn't so good at preventing this other problem of in-stent restenosis. So as it turned out, the bare metal frame irritated the vascular endothelium, causing dedifferentiation of the smooth muscle cells below it, causing them to proliferate and grow into the vascular bed, causing in-stent restenosis. So to combat this issue of neointimal hyperplasia, they decided to coat an anti-proliferative chemotherapeutic agent, sirolimus, onto the stent. And the sirolimus was great at preventing in-stent restenosis. However, it also delayed the normal and wanted endothelialization of the vascular bed, still, and thus leaving these extra little areas for thrombus to form. So at this time, they decided to increase the duration of dual antiplatelet therapy from 4 weeks to 3 to 6 months. Unfortunately, this seemed to be a bit of an underestimate, and by 2006, there were growing concerns of this entity of late thrombosis. So they decided to increase the recommendation for dual antiplatelet therapy to at least a year. All the while, engineers continued on working on less thrombotic stents by making the struts thinner and making more advanced polymers that store and release the drugs, such that by 2016, they were able to relax their recommendations back to 3 to 6 months for individuals considered to be at higher risks of bleeding. And as I alluded to earlier, with the recent release of the 2021 American College of Cardiology Revascularization Guidelines, they opened the door with a 2A recommendation to just 1 to 3 months of dual antiplatelet therapy for certain individuals. But just to recap, in the bare metal stent era, we started with dual antiplatelet therapy at 4 weeks, which was increased to 3 to 6 months with the introduction of the drug-eluting stent due to delayed endothelialization, which was increased further to a year with recognition of late thrombosis, which was relaxed to 3 to 6 months with the evolution of less thrombotic stents for patients at higher bleeding risks, now with the door being pushed even further back to 3 months and possibly 1 month for certain individuals. But in considering the shortest and safest duration of dual antiplatelet therapy for Mr. Stent, there's more to the story than just stent design. Another crucial component of all of their algorithms is consideration of why the stent was put in. Was it put in because of stable ischemic heart disease or acute coronary syndrome? So turning briefly to the 2016 American College of Cardiology guidelines, we see that they provide a class 1 recommendation for at least 12 months of dual antiplatelet therapy if the stent was placed because of acute coronary syndrome, whereas 6 months of dual antiplatelet therapy seem to be sufficient for patients stented with stable ischemic heart disease. They relaxed these recommendations to 3 months and 6 months respectively for individuals considered to be at higher risk for bleeding. And we see here on the right some of the data that inform these decisions. So on the y-axis, we're looking at the percentage of major adverse cardiac events defined as MI, revascularization, or death within 30 days of a non-cardiac surgery. And for the patients who were stented due to a myocardial infarction, seen in this red line, we see that the rates of MACE are pretty high within the first 3 months, compared to if the stent was placed because of stable ischemic heart disease, shown here in blue. So with that in mind, the Americans set their class 3 recommendation for not proceeding to surgery with a class 3 do not proceed at just 3 months. And this is in contrast to our European colleagues who set their class 3 recommendation saying do not proceed to surgery at just 1 month. Citing some observational studies shown here, where on the y-axis, we're looking at the percentage of postoperative myocardial infarctions within 12 months, and they separated the groups based on if they waited less than 1 month to go for their surgery from the time of stent placement to if they waited just 1 to 2 months. And as we see, the longer you wait, the lower the risk of postoperative MI. This past December, the American College of Cardiology released a new set of guidelines, which starts off looking pretty similar to the 2016 edition. Once again, they start with a class 1 recommendation for at least 12 months of dual antiplatelet therapy if you were stented due to acute coronary syndrome. And once again, just 6 months of dual antiplatelet therapy if you were stented due to stable ischemic heart disease. Once again, they relax these recommendations to 3 months and 6 months respectively if you're considered to be at a higher risk for bleeding, but here they specify that it's a class 2B recommendation if you drop the P2Y12 inhibitor and continue aspirin monotherapy. And interestingly, in this new set of guidelines, they open the door with a class 2A recommendation for just 1 to 3 months of dual antiplatelet therapy if you drop the aspirin and continue P2Y12 inhibitor monotherapy. And they base these recommendations largely on 5 major trials, 4 of which I've included here, 1 of which I've excluded simply due to screen real estate. And before I bore many of you with some of the details of these studies, I'll make a long story short and tell you that in aggregate, they showed about a 40% reduction in major bleeding with no statistical difference in major adverse cardiac events. In view of trying to finish on time, I won't give a justice to these studies, but will simply mention that they were all relatively large in size, with populations in the thousands, all with a mean age of about 65 years. Here on the y-axis, I'm representing the percent of patients who were stented due to stable ischemic heart disease, shown in blue, versus acute coronary syndrome in orange. And we see across all of these trials, there's a mix of patients with both stable ischemic heart disease and acute coronary syndrome, with Twilight having the highest proportion of patients with acute coronary syndrome. Shown here in red, I'm representing the patients with acute coronary syndrome who presented with STEMI, and we'll note that although the Twilight trial had the highest proportion of patients presenting with acute coronary syndrome, they actually excluded patients who presented with STEMI, while the other trials had a range from 10 to 20%. Each of the trials picked their favorite drug-eluting stent. Suffice to say, they were all newer generation and coincidentally contributed some money to the trials. And in terms of trial design, they all had a similar setup. They all started with one group that started on a short duration of dual antiplatelet therapy. And in these first 2 trials here, this short duration of dual antiplatelet therapy was for just 1 month. And for these 2 trials over here, the short duration of dual antiplatelet therapy was for 3 months. This short duration of dual antiplatelet therapy was followed by a longer period of P2Y12 inhibitor monotherapy. And that group was compared to an arm that got dual antiplatelet therapy for a longer duration of time, usually a year. Once again, on the y-axis here, I'm going to represent some of the outcomes from these trials. So on the y-axis, I'm showing the percentage of patients capping at 3% who in the blue arm was the short arm of dual antiplatelet therapy. And in the orange bars, I'm representing the arm of the studies that got the longer duration of dual antiplatelet therapy. And what we see here was that there was no statistical difference in rates of death, nor was there a statistically significant difference in rates of death due to cardiovascular causes, nor was there a statistically significant difference in rates of stent thrombosis. However, it's important to note that these trials weren't powered to comment on this accurately. However, it's interesting to note that the arm that got the longer duration of dual antiplatelet therapy in the Twilight trial actually had a trend towards increased stent thrombosis. And none of the trials showed a statistically significant difference in rates of myocardial infarction. Where they did show a statistically significant difference was in rates of major bleeding, which they call BARC 3 or 5 bleeding, which is a way of saying that a patient dropped their hemoglobin to 5 or required vasopressors or resulted in death. So in both the DAPT trial and Twilight, we see a statistically significant difference in major bleeds. So in sum, these 5 trials were analyzed in a meta-analysis with the conclusion that they showed a 40% reduction in major bleeding with no statistical difference in major adverse cardiac events. Interestingly, 2 additional trials released their data after the guideline committee closed their doors to further literature review, and that was MASTER-DAPT and STOP-DAPT2 ACS. I won't torture you with any more graphs, and we'll just summarize these trials by pointing out that the MASTER-DAPT trial focused on a population of high bleeding risk patients and supported the story that I told previously, which was that 1 month of dual antiplatelet therapy was non-inferior to standard antiplatelet therapy. This second trial, STOP-DAPT2 ACS, focused exclusively on a population that was stented due to acute coronary syndrome, but unfortunately failed to meet their non-inferiority endpoint, demonstrating a worrisome increase in some cardiovascular events, which I've represented here. You can see their rates of stent thrombosis and myocardial infarction, with a trend towards an increase in the arm that got just 1 month of dual antiplatelet therapy. So while I think the 2021 American College of Cardiology revascularization guidelines communicates a message of how cardiologists are starting to think about dual antiplatelet therapy after stent placement, unlike their 2016 predecessor, they don't specifically provide guidance in the perioperative period. And I wouldn't necessarily extrapolate their recommendation, their class 2A recommendation for just 1 month of dual antiplatelet therapy, simply because these trials all relied on defaulting to P2Y12 inhibitor monotherapy. And while I mentioned that surgeons these days seem to be okay operating with aspirin running in the background, we don't have much data to inform operations on P2Y12 inhibitor monotherapy. But returning to the case of Mr. Stent, since his stent was placed 5 months ago in the setting of stable ischemic heart disease, we felt comfortable telling him that he could schedule a colonoscopy in 1 month with a plan to hold his P2Y12 inhibitor, clopidogrel, given his positive fecal immunochemical test and the possibility that they would need to perform a polypectomy. And in going through the case of Mr. Stent, we saw that as stents have gotten less thrombotic, recommendations for dual antiplatelet therapy duration have continued to decrease, but that it's still important to consider whether the stent was placed due to acute coronary syndrome or stable ischemic heart disease when considering dual antiplatelet therapy interruption. So with the case of Mr. Stent tucked away, I'll turn to the case of Mr. A-Fib. Not to worry, however, there's much less literature to review regarding the direct oral anticoagulants in the perioperative period. So Mr. A-Fib was a 76-year-old man with hypertension, diabetes, and as you probably guessed, atrial fibrillation, for which he was taking apixaban with a calculated CHADS-VASc score of 4. And the CHADS-VASc score just refers to his thrombotic risk over the course of the year. And he gets 1 point for having hypertension, 2 points for having an age greater than 75, and 1 point for diabetes. And we can see that with a score of 4, that correlates to a roughly 4% yearly risk of stroke and less than 0.5% weekly risk of stroke in the absence of that anticoagulation. And he was referred to us from his dentist for a tooth extraction. So similar setup to Mr. Stent, first we'll consider, does he need to stop his bloody medication? And once again, this will come down to his proceduralist, in this case, the dentist. But we know that procedures that are low bleeding risk, such as biopsies of the skin, avascular tissue of the eye, such as cataracts, or excision of just 1 to 2 teeth, you usually don't need to hold the anticoagulation. But anything that's not considered to be a low bleeding risk procedure, you likely will. So that makes things pretty easy for us regarding Mr. A-Fib. Since he's having just 1 tooth extracted, we know that he can probably continue his direct oral anticoagulant safely during the procedure. And in fact, there's a pretty large body of literature published in dental journals that assures of this safety of extracting 2, maybe even 3 teeth on full anticoagulation. But once again, this will come down to the proceduralist, in this case, the dentist. But to make this case a little bit more interesting, we could pretend that maybe he needed 4 teeth extracted, maybe he needed a total knee replacement, something that was a higher bleeding risk that would require him to stop the direct oral anticoagulant. So your next question might be, well, when do you need to stop? And to answer this question, there's a few different places we can turn. There's the package insert. There's the guidance from the 2017 American College of Cardiology Expert Consensus Pathway, published by Dr. John Doherty, and the 2018 American Society of Regional Anesthesia Guidelines. But they all pretty much say the same thing, which is that if you're taking apixaban or rivaroxaban, you should probably stop 2 to 3 days before the procedure. And if you're taking dabigatran, it's a little bit more complicated because it has 80% renal clearance, so you might have to stop 3 to 5 days before, depending on how bad their kidneys are. But once you've made the decision that you need to stop, the next question you might have is, do you need to bridge these direct oral anticoagulants? And the answer to this question is basically no, as supported by the 2019 PAUSE trial, co-authored by Northwell's very own Dr. Spiropoulos. And what the PAUSE trial asked is a simple fixed strategy of direct oral anticoagulant interruption safe? And to answer this question, they looked at about 2,000 or 3,000 patients with atrial fibrillation who were taking apixaban, rivaroxaban, or dabigatran, and they said, if you were going for a low bleeding risk procedure, we'd tell you to stop the agent a day before the surgery and restart it on post-op day 1. And if you were going for a high bleeding risk surgery, we'll tell you to stop it 2 days before the surgery and resume it on post-op day 2. They defined the low bleeding risk surgeries as the ones we've already discussed: cataracts, skin biopsies, excision of up to 2 teeth. And the high bleeding risk procedures were anything that required neuroaxial anesthesia, surgeries on the abdomen for cancer resection, or orthopedic surgeries of the hip, knee, or shoulder. And what they found was that with this simple fixed strategy, they tended not to have very high rates of major bleeding, never exceeding 2%. And they also didn't have high rates of arterial thromboembolism, never really exceeding over 0.5%. So they concluded that a simple standardized approach to direct oral anticoagulant interruption is safe. And since Mr. A-Fib over here has a CHA2DS2-VASc of 4 and he's going for a very low bleeding risk procedure, we decided that we could defer to the dentist, but tell him that he could continue his anticoagulant during the procedure. So with the case of Mr. A-Fib tucked away, I'll move on to the last and final case, Mrs. Mechanical Mitral Valve, who is a 65-year-old woman with severe osteoarthritis and rheumatic heart disease, for which she had a mitral mechanical valve placed 20 years ago, for which she's currently taking warfarin. And she was referred to us with a plan for total knee replacement in the setting of her severe debilitating osteoarthritis. So similar considerations for Mrs. Mechanical Mitral Valve. First, we'll consider if she needs to stop the medications, which will come down to the proceduralist, but we know that since a total knee replacement is not one of these low bleeding risk procedures, she'll have to stop her anticoagulation. Regarding the question of when to stop her warfarin, we can turn to the same places we did for Mr. A-Fib, and pretty much all of these agencies agree that for warfarin, you should stop at least 5 days before the surgery. Where things get interesting is consideration of the need to bridge. So to answer this question, there's a few different places we can turn. There's the 2017 American College of Cardiology Guidelines and the 2017 European Society of Cardiology Guidelines. And each of these agencies looks at 3 particular factors: the valve position, the valve design, and patient-specific risk factors. For valve position, they consider whether the mechanical valve is in the aortic or mitral position. In terms of valve design, they consider whether it's ball and cage, tilting disc, or bileaflet. And in terms of patient-specific risk factors, they consider whether the patient has a history of atrial fibrillation, previous thromboembolism, hypercoagulable condition, or an ejection fraction less than 30%. And the aortic and the bileaflet valves are considered to be less thrombotic. So if all of the stars align and you have an aortic valve that's bileaflet and none of these risk factors, they say that you don't necessarily need to bridge. But if you have any of these other risk factors, you probably do. So in turning to the case of Mrs. Mechanical Mitral Valve, this makes things pretty simple for us. Since her valve is in the mitral position, we know that their recommendation is for us to bridge. And while I could end the story here, this past September, a paper was published, the PeriOp 2 trial, which might color how we consider this algorithm. But before I dive into the PeriOp 2 trial, I'll set the scene with its predecessor, the 2015 Bridge trial. So the 2015 Bridge trial, which was also co-authored by North Wales and Dr. Spiropoulos, asked the question, does bridging reduce the rates of stroke in patients with atrial fibrillation? So they looked at about 2,000 patients with atrial fibrillation who were planned for surgery and told them to stop their warfarin 5 days before the surgery and resume it on post-op day 1. Half of the group got bridged with a low molecular weight heparin, dalteparin, on days -3, -2, and -1 before the surgery, with resumption of the dalteparin on post-op day 1. And the other half got just placebo. And what they found was that between these two groups, there was no statistical difference in rates of arterial thromboembolism, which is to say strokes, but there was a statistically significant increase in the rates of major bleeding in the group that got the dalteparin bridge. If we look at the thrombotic risk of the patients that were in the study, we see that they had a roughly a mean CHA2DS2 score of about 2.3. And now if we turn to the setup for the PeriOp 2 trial, we see a very similar design. Once again, they took about 1,500 patients who were planned for surgery with atrial fibrillation who were taking warfarin. And once again, they told them to stop their warfarin 5 days before the surgery. This time they had them resume it on the day of surgery. And here they had all patients preoperatively bridged with dalteparin on days -3, -2, and -1 before the surgery. And it was post-operatively that they were randomized to either continue dalteparin or get placebo. And what they found was that between these two groups, there was no difference in rates of arterial thromboembolism and actually no rates in major bleeding. And if we look at the thrombotic risk of the group that that was in the PeriOp 2 trial compared to the bridge trial, here in red, I've represented the CHADS 2 scores of those in the bridge trial, and in blue, those in the PeriOp 2 trial. And we see that although in the PeriOp 2 trial, there were a few more patients with CHADS 2s of 5s and 6s, they were pretty similar in this group with a mean CHADS 2 score of 2.4 compared to 2.3 in the bridge trial. So nothing really to write home about. But what was interesting was that over 20% of their patients had prosthetic mechanical valves, with almost half of those having valves in the mitral position. And even in this group with the mechanical valves, we see no statistically significant difference in rates of arterial thromboembolism. And actually the one stroke that did occur was in the group that got dalteparin, and there was no significant difference in rates of major bleeding. So they concluded that bridging did not lower the rates of arterial thromboembolism in patients with atrial fibrillation or with mechanical heart valves. So even though I think the PeriOp 2 trial provides some interesting new information to consider when considering bridging for patients with mechanical valves, it's not guideline changing at this time. So for Mrs. Mechanical Mitral Valve here, we decided to stick with the traditional guideline-directed approach of checking her INR 7 days before the surgery, holding her warfarin 5 days before the surgery, starting a low molecular weight heparin bridge 3 days before the surgery, with one more INR check 1 day before the surgery. So in summary, in reviewing the case of Mr. Stent, we saw that as stents have gotten less thrombotic, recommendations for dual antiplatelet therapy duration continue to decrease, but that it's still important to consider whether the stent was placed because of acute coronary syndrome or stable ischemic heart disease. In reviewing the case of Mr. A-Fib via the PAUSE trial, we saw that there really doesn't seem to be a role for bridging the direct oral anticoagulants in the perioperative period. And in reviewing the case of Mrs. Mechanical Mitral Valve, we saw that bridging remains questionable, as even those patients in this trial who had mechanical valves showed no benefit with a bridging strategy. And once again, even though I've focused on just a few of the key components of each of these algorithms, the nuances are vast and constantly evolving. And for that reason, multidisciplinary decision-making with cardiology, surgery, and anesthesia remains very important. And for those of you who have made it this far, I'd like to thank you for your time and attention. And I actually have one extra slide that I put in at the recommendation of Dr. Friedman, which is that not everyone is necessarily familiar with Dr. Glaucomaflecken or Glaucomflocken. So for those of you who aren't, I've left a QR code to his YouTube channel, and I promise if you check out some of his videos, you won't be disappointed.
That was absolutely amazing, Mark.